a really great group of speakers who are very knowledgeable in pediatric readiness, have worked in their region and their state. And so our title, as we said before, Pediatric Readiness, Critical Steps to Pediatric Disaster Preparedness. Next slide.
So I can go ahead and get started. So my name is Joyce Lee. I'm one of the, oh, sorry, go ahead.
No, I can just say these are our speakers. So Joyce Lee is going to kick us off, who runs regional work for EMSC, Emergency Medical Services for Children. Later, we'll hear from Anna Sessa from New Hampshire, Michael Goldman from Connecticut, and then we have Michelle Megling, who's the co-lead for the EMSC IIC hospital domain, as well as a Region 5 for kids. That's one of the ASPR Pediatric Centers of Excellence, subject matter experts and project managers. So next slide. So our learning objectives is to review the intersection of pediatric readiness and healthcare disaster planning. That requires a special focus on kids, including triage, special healthcare needs, guardianship, and family reunification. We really want to discuss how improving everyday pediatric emergency care capabilities in the ED can improve readiness for a pediatric response to large-scale events. And the most important thing, I think, is really to share with you and share how you can get to high quality resources that are available to healthcare organizations to help you improve your pediatric emergency care capabilities, including resources that have been developed through the National Pediatric Readiness Project. So I'm going to turn it over to Joyce.
Yeah, so thanks so much for having me. So my name is Joyce Lee. I'm a pediatric emergency medicine attending at Boston Children's, but I also do a lot of regional work and oversee a network of PECs. And if you're not familiar with that term, I'll explain it more in a minute. I also help with regional liaison. Oh, I can try to turn up my, let me know if anyone else is having trouble hearing me. I'm also the regional liaison for Massachusetts EMSC. Next slide. I have no financial disclosures. Next slide. So I wanted to start off with a case, and this is a real case. Some people have already read about this, but a 3-year-old girl named Avery shows up at a rural ED with a history of epilepsy and status epilepticus. During that case, the ED doctor attempts to intubate her when she is having trouble breathing. The ED doctor initially tries using an adult-sized tube. After failing to intubate, they try smaller tubes, were unable to intubate. And unfortunately, the patient had cardiac arrest due to hypoxia. After 6 rounds of CPR with adult doses of epinephrine, they end up having ROS, but never able to intubate. Avery was eventually transferred to the local children's hospital where she was intubated on the first attempt. But unfortunately, this patient had brain death and died 6 days after admission. Next slide. 20 years earlier, a 6-year-old boy named Matthew presented similarly to the same ED and also died after failed attempts at intubation. Next slide. So you may already know these cases because these cases were talked about in a series of Wall Street Journal articles about pediatric readiness. And the concern is about how emergency departments in certain areas may not be adequately prepared to care for critically ill children and the consequences of that. Next slide. So we already talked about this, but I'm going to be reviewing so this is going to be a very brief overview of that intersection of pediatric readiness and healthcare disaster planning, how to improve everyday pediatric emergency care capabilities, and then Michelle will be talking more about the resources available. Next slide. So what is pediatric readiness? Pediatric readiness, or the concept of being pediatric ready, is really the ability to provide high quality care to pediatric patients with the goal of reducing morbidity and mortality due to severe illness or injury among children. As many of you probably already know, children have unique physiologic and anatomic needs and therefore need appropriate equipment, appropriate medication plans, and just appropriate plans for them in general that will differ from adults. In 2006, the Institutes of Medicine, now known as the National Academy of Medicine, released a report called Emergency Care for Children, Growing Pains. Basically, the whole report details how they did large-scale surveys of emergency departments and found that they were not adequately prepared to take care of pediatric patients. One of the ones that I point out is only half of the hospitals had at least 85% of the necessary pediatric emergency equipment to care for children. Oh, I'm not sure how else to turn up my, I have my microphone as high as I can. I'll try to speak louder. So pediatric ED patients, as far as who can be seen and who cannot be seen, pediatric ED patients, as far as where they're seen. So 80 to 90% of children are cared for in general ED settings. But this is contrasted by the fact that from the ED's perspective, 81% of them see less than 10 pediatric patients per day. And so this is a hard juxtaposition, right? The majority are seen in general EDs, but from their perspective, they're not necessarily seeing a large volume. And then the graph on the right is from the CDC data. And basically what you can see is has to do with what age groups are, from their perspective, are more likely to present. And so children less than 1 is a very common age group that will seek care in emergency departments, followed by the geriatric population. Next slide. And so there are 2 studies, major studies that have looked at what are the outcomes of these children when they go to emergency departments with varying degrees of pediatric readiness. One looked at more overall medical illness, and then one was specifically looking at trauma. Next slide. And so what they found in these studies is that lower pediatric readiness scores, meaning scores less than 87, was associated with higher mortality. And so the highest score you can get is 100. And high pediatric readiness EDs, they found that their mortality rate was 76% lower in ill children overall, and 60% lower in children with trauma or in trauma centers. And what this has worked out to is that at least 1,400 children's lives per year could be saved if these patients have been seen in high pediatric readiness EDs. Next slide. So how do we work with this juxtaposition? Again, EDs that are not necessarily seeing a large volume of patients, but from the perspective of the pediatric population are mostly seen in general EDs. And so the National Pediatric Readiness Project is a project led by the Emergency Medical Services for Children, which is a federal agency that also has statewide agencies as well. And what this was in collaboration with the American Academy of Pediatrics, the American College of Emergency Physicians, and the Emergency Nurses Association. And the goal of this project is really to provide resources and support for all EMS agencies and EDs so that they can be pediatric ready. And so this really, the first survey of the Pediatric Readiness Project went out in 2013. And since then, the studies that I pointed out and increased resources have been provided for EDs in order for them to be more pediatric ready. And some of you have heard that there's also now been the start of an EMS Pediatric Readiness Project in the pre-hospital setting as well. Next slide. So this is what the pediatric readiness in the ED department, the checklist looks like. It's a longer list. Obviously, this is just the first page. Next slide. But there are basically 7 domains within this checklist. So one is administration coordination, ED provider pediatric competency, quality improvement, policies, procedures, and protocols, support services, safety guidelines, and equipment and safety supplies and medication. Next slide. So I wanted to talk a little bit about the just general recommendations for policies and procedures within disaster, that there are a list of recommendations. So one is that medications, vaccines, equipment, supplies, and trained providers are prepared for children in disaster. The care of children with special healthcare needs may need a specialized focus. Minimization of parent-child separation, tracking and reunification of children and families, and then the pediatric surge capacity for injured and non-injured children. For people who may have remembered, 2022 was a particularly challenging time when we had a pediatric respiratory surge, or the triple pandemic was a time that pediatric surge capacity would have been an example of trying to use some of those policies. Decontamination, isolation, and quarantine of families and children of all ages. access to special behavioral health therapies and social services for children, and then disaster drills, including a pediatric mass casualty incident at least every 2 years. Next slide. So what I wanted to point out is something called the forgetting curve, which we probably all know of, but to kind of say out loud. So we know that in general, disaster events are generally rare, unfortunately becoming more common, but again, not necessarily an everyday occurrence. And even the presentation of critically ill children can be rare, but probably more frequent than disasters. And so when we have these kind of rare events, we have a tendency to forget, right? So things that we may have learned, if we don't use it pretty frequently or regularly, we will eventually forget them. And so what you can do, though, to ameliorate this forgetting curve is to have intermittent things, whether that's actual cases or just practice cases like simulation, or even just having mental thought exercises, thinking about these kinds of situations, will refresh the memory of what you have learned. But actually what they've shown is that if you do this regularly over time, you eventually take that short-term memory education, and it becomes long-term memory, and it becomes more solidified in your head, even if you haven't been using it as often. And so one of the things I wanted to point out is this idea that when we are doing pediatric readiness on an everyday situation, we're really actually helping it become, a lot of that information is very similar to what you need in a pediatric disaster. And it's going to actually solidify that information, both so that you can both care for pediatric critically ill patients on an everyday basis, but then you're actually more prepared from a disaster level. Next slide. So I just wanted to show some examples on how, if you're ready on an everyday basis, you're also going to be more prepared for disasters. So for example, the equipment and supplies, I didn't show the entire list. There's a long list, as you can imagine, of pediatric supplies that they recommend. And this is from the Pediatric Readiness Project. Next slide. And there's some very basic tenets that they also apply and recommend. And as you can tell, these tenets really are also going to support your disaster equipment and being prepared for pediatric patients in a disaster situation. So making sure that your equipment is easily accessible, clearly labeled, and logically organized. That the ED staff knows where all these items are. And so, for example, we know that in basic cases, so that case with Avery at the beginning, it sounds like they probably went to the adult size tube because they couldn't find the smaller tubes or the appropriate size tubes. And that's unfortunately a very common thing that we have seen in cases. And so one example of something you can do is something called a scavenger hunt. So for example, someone, say an administrator or someone who is overseeing the pediatric care in your ED, would send out an email to all of the staff that said something like, a 3-month-old in respiratory distress presents to our ED. Can you find the 3.5 ET tube? Please, during one of your shifts, when you have a little downtime, try to physically find this tube. And then maybe a week later, you send the answer to everyone. And this is an example where you are doing these little mental exercises to refresh memory about knowledge you probably had, and that will hopefully solidify with time, but also helps people to just acclimate to this idea that what would I do if a pediatric critical care patient came in? Just sending out that type of email, I think a lot of people would start thinking like, do I remember where everything is? Do I remember where the infant warmer is? Do I know how to use it? And so that's just an example where it would help with you on a pediatric readiness everyday basis, but obviously during a disaster, you need that information as well. So having a daily method in place to verify the proper location and function of pediatric equipment and supplies, a standardized chart or tool used to estimate weight in kilograms if resuscitation precludes the use of a weight scale, and then a medication chart, length-based tape, medical software, or other systems to ensure proper sizing or resuscitation equipment and proper dosing of medications. And so an example of that would be a Broslo tape. Next slide. So what about some other policies and procedures? So there are recommendations that there should be a pediatric specific triage policy and include things like identification and notification of the responsible provider of abnormal pediatric vital signs. And I just wanted to give you an example of where an everyday procedure or policy would then be applicable to disasters. Next slide. So one system that's actually recommended for pediatric patients is something called the Pediatric Assessment Triangle. And what this is that this is a specific kind of system that you see on the left, working within 3 domains. But basically what studies have shown is that this helps identify critically ill children earlier. It's a very quick system of assessment that can take less than a few minutes. And if you think about things like Jumpstart, there's another one called SMART. There's all sorts of different pediatric disaster triaging systems. But when you look at these other systems, there's a lot that actually basically crosses over. And you can imagine that if someone is very used to doing the pediatric assessment triangle on pediatric patients, it's only going to facilitate their ability to do disaster triage on pediatric patients when there are multiple critically ill pediatric patients that are coming in. And so this is another example where one side of the training, the everyday training, actually will very easily cross over to the disaster training, and sometimes may overlap. Next slide. The major one that you probably all know of about children in disasters is family reunification. So this is a unique pediatric disaster issue where you have children that may have been separated either on purpose or due to the nature of the disaster. For example, they were at school. And now you have to figure out how to both identify them, confirm their identity and who their guardians are, and then have a plan for children that don't have a provider or you're not able to identify them. And one of the recommendations is having 4 separate areas, which is a pediatric safe area, a family assistance center, family reunification center, and a media center. The pediatric safe area is where unsupervised children or children where you're still trying to confirm their identity or guardianship would go. Family assistance center is where the families would go. So as families start showing up to your emergency department, and the family reunification center is where you would obviously bring children and families back together, but it's also where you would explain to a family or parents or guardians that unfortunately their child had passed away. Next slide. So when you look at some of the policies and procedures that are recommended, again, on a pediatric readiness basis or an everyday basis, you'll probably, as I start explaining them, you'll see how much they cross over with family reunification center and disaster planning. So some of the policies that are recommended are death of a child in the ED, and that would include bereavement counseling. There are a variety of recommendations in regards to children with special health care needs and having appropriate policies and procedures for them. Consent for care, including when guardianship is not available, and then behavioral health policies and procedures. And I just wanted to show you a very specific one, just as an example. So within the New England region, we have a New England EMSC website, and we have a behavioral health toolkit. One of those very specific tools is something called the Activity Resource Packet. And on there, we have a list of items that are safe for pediatric patients. It specifically is safe for mental behavioral health patients, meaning that, for example, like they don't have wires, they don't have other things that could be potentially be harmful. And they're actually separated by age. And we have even recommended ways that you can make your own little kits based on age. Next slide. So as you can even see and think about, like these things that you would have on an everyday basis could very easily be transitioned in a disaster situation or would just be used exactly the same way. So the activity kits, for example, if you were to start having those activity kits for just any boarding pediatric patient, but specifically for your boarding pediatric mental behavioral health patients, that those supplies could very easily then be used in your pediatric safe area. So when we talk about the pediatric safe area as an area where children would be where they would be placed while you're trying to confirm their identity, one of the things you need to have for them is you need something to occupy their time. So this is something that could very easily be translated over. Bereavement counseling and death of a child obviously could be used in both situations. And then again, children with special health care needs, if you had a disaster situation that involved children with special health care needs, if it happened at a specific school that maybe this is the majority of the population, a home where these children are staying, again, those policies would very easily cover both. Next slide. And then I just wanted to give a special kind of shout out to the administration competencies section. And so part of the major recommendations on the pediatric readiness project is the assignment of a pediatric emergency care coordinator or a PEC. What that is basically a nurse and physician team within an ED whose purposes are to basically oversee the pediatric care within their ED. They don't need to be pediatric specialists per se, just a specialist of their ED and someone who's really just actively monitoring how the pediatric care is happening in their ED. And so studies have shown that having a PEC has been associated with increased pediatric readiness scores. And within disaster, there is a suggestion or recommendation of having a disaster pediatric coordinator. And so really the pediatric emergency care coordinator and your disaster pediatric coordinator could very much easily work together to make sure that competencies are being accomplished, that disaster drills are including pediatric content, and then both of them can work together for ongoing pediatric education and preparation. Next slide. And so where do we stand as a region within New England? So again, just as a reminder, where the goal is to have a pediatric readiness score over 87. What you see for these individual states is basically the average pediatric readiness score. So we're actually doing pretty well in general, but we all have more to work on, and we have room to grow to get to that score, average score greater than 87. Next slide. So in summary, the majority of children are seen in general EDs where most see less than 10 pediatrics per day, and lower pediatric readiness scores have been associated with high mortality. But being pediatric ready is a major step towards large-scale disaster preparedness, and one of the ways that is a great way to start is by establishing a PEC. Thanks so much. I'll turn it back over to Sarita.
Yeah, thank you so much for that presentation and start. And for everyone on the webinar, if you have any questions, please throw it in the Q&A, and we hope to get to all your questions at the end. And if not, we will hope to circle back with you afterwards for your answers. But I think as you set the stage of pediatric readiness, we wanted to turn to some experts in our region who are working on pediatric readiness projects in their state and also disaster projects in their state. So I'd like to do is actually turn it over to Anna Sessa right now, who is the program manager for EMSC for New Hampshire, and just would love to hear a little bit about what you're doing in New Hampshire to share examples of things that are going on in our region.
Absolutely. Thank you all. I have a four-legged office mate, so bear with me as you hear noises in the background. Thanks for having me. My name's Anna. I manage New Hampshire's EMS for Children program, as Dr. Chung related to. We have a unique position here in New Hampshire in that our EMS for Children program sits at the academic medical facility and not the state level. And while this brings certainly hurdles to state mandates and communications with sites, it also allows us a direct connection to our academic medical facility at Dartmouth-Hitchcock Medical Center. And then Dartmouth-Hitchcock is part of a larger network of sites, both EDs, hospitals, and clinics through the Dartmouth Health Network. So at EMS for Children in 2021, our NPRP assessment results, so National Pediatric Readiness Project Assessment, showed that less than 30% of our sites spoke to pediatrics specifically as it relates to the disaster planning. And while this hit us on the radar, it really didn't become a larger concern until disaster planning became a larger part of the EMS for Children programming. And while we know that most, if not all, sites have have disaster plans, they don't speak to specifically to pediatrics. And as we all know, in this group here, pediatrics come with specific needs that, when you have a general disaster plan that speaks to all patients, it doesn't include those more refined details like reunification that pediatrics come with. So recently, the New Hampshire EMS for Children Program Director, Dr. Maya Ruttman, who's the PEM at Dartmouth-Hitchcock, and myself were invited to sit as the pediatric experts on the Dartmouth-Hitchcock Emergency Management Steering Committee. And I'm happy to say that since we've been on that committee, pediatrics has come up at every single monthly meeting, which is fantastic. And we're even looking at including now pediatrics in an upcoming exercise for evacuation planning. So the goal with this new role is to identify gaps at our largest facility so that we can create better templates and resources, not only for Dartmouth-Hitchcock, but then we can bring them to other smaller Dartmouth Health sites, starting, of course, with EDs and hospitals, and then be moving down the road, better preparing our clinics, not only in New Hampshire, but we also have a couple of sites in Vermont as well. And this brings up the idea, and I'm really excited about this meeting because of this regional approach to disaster that we see across the country, and regional approach that has been so prevalent and so progressive for our EMS for Children programs and program managers across the Northeast region, that really this is the first stepping stone to creating a regional approach to pediatric disasters. And this is not a new thing, but definitely something that I'm excited to get the ball rolling on. As we all know, patients are crossing borders on a regular basis. It behooves us to have a unified approach to this. So in addition to, again, starting at Dartmouth Hitchcock and then reaching other networks down the road, I'm also starting to chew on this idea, and it's just a new burgeoning idea that I have, and I'm eager to talk to other folks who have more experience in this, is the idea of creating a pediatric disaster supply caches. So this, in my head, would be, you know, just-in-time training, social emotional support, reunification supplies that we might have stored at 1 or 2 sites across our state. If we can manage it and, you know, verify, if I can use that word, from the EMS for Children standpoint, not only could we have these supplies across the state, but we could also allow not only the sites that store the supplies, but also allow all facilities to have access to this, which, as Dr. Lee had mentioned, you know, 80 to 90% of our pediatric patients are seeking care at their general hospital nearby. If all hospitals across the state could have access to these supplies, then we know that all pediatric patients could also be supported by these supplies. So approaching this not only from a health network standpoint, but also, you know, reaching not only our larger facilities, but also our smaller facilities to support all pediatric patients or uninjured patients that seek, you know, respite at our hospitals. We really can reach all sites and all patients. So a couple of things there on New Hampshire's radar. And again, if anybody has experience with pediatric disaster supply caches, I've created my own list, but looking to add stuff to the list to make it more comprehensive. I'm certainly open to that. And once again, thanks for having me. And I'm really excited about what we can do through RDHRS and our EMS for Children programs to get this really rolling on a regional basis. So thanks.
Thank you, Anna. That's really exciting to kind of consider and think. And as you mentioned, part of this webinar is just a stepping stone to think about how we think about pediatrics in our region on our RDHRS. So we're hoping to, if you are interested, have members through our region to start forming a task force to consider items. And next I want to turn to Michael Goldman. Michael Goldman is an associate professor of pediatrics emergency medicine at Yale School of Medicine, but also one of the leads or co-leads of Connecticut EMSC, and really has been a leader of pediatric readiness projects in Connecticut and a role model for nationally. So Michael, I'm going to turn it over to you.
All righty. Hi, everybody. I appreciate the opportunity to share some of the hard work that's going on in Connecticut. I want to make sure I call special attention to Megan Petroselli, who's on the call as well, who's my absolute partner in crime, the leader of our team, and is incredible, the amount of effort she puts into all the work that we're doing. I'm not going to focus too much on disaster preparedness work because I think Joyce and Anna have already spoken extensively about it, and we also have other kind of initiatives going on in Connecticut through the Pediatric Pandemic Network and work that Dr. Cicero, Mark Cicero is spearheading that we can talk about offline if you want more information about what we're doing locally for disaster preparedness. So I'll speak more to sort of everyday pediatric readiness and some of the efforts that we have in the past and certainly are ongoing, just to get us a flavor of the work we do. I'd say broad strokes, perhaps our most successful work product thing that we do is that we go into the community emergency departments and EMS agencies, and we run what we call in situ simulations, where we try and go on a near monthly basis to a different part of our state. We try and engage both local EMS agencies and the local community emergency department and run big simulations that mimic the continuity of care from out of hospital, pre-hospital setting to the community emergency department, all the way until the sims always end to, okay, now you're calling the pediatric transport team to get them to the children's hospital. So really thinking about where children land in that continuity, as Joyce outlined, 80% of children are being seen first far away from the regional children's center. So simulations are fantastic. We choose our cases ideally with what the local emergency department and EMS agencies saw recently and what they're thinking about, having some flashbacks as to how it went with a real patient, so that we can course correct and offer some education. I'll say the biggest take home from doing the simulations, however, is to make sure that everyone creates that psychological safety so that everyone understands that no, we are not coming to judge, we are not coming to grade, we're not coming to do anything about your individual people that work at these different institutions. We're talking about the system of care. And so that if our simulation uncovers that nobody knows where the newborn baby warmer is or how to turn it on or something like that, that's excellent. That's exactly what the kind of stuff we'd like to do, so that next time if there's a precipitous delivery in the parking lot, that local hospital is ready to go. So I'd say that's probably the biggest thing that we do in Connecticut. There's lots of other projects that I can highlight. We were involved in developing transfer guidelines so that community hospitals could think about where to send children. Our state is odd in a way. It's quite small and quite dense in its pediatric care, and also quite close to states like Massachusetts and New York and Rhode Island, where other kind of big centers can be referred to. So we put together guidelines about both speaking to where to send the kid, but also about what modality to use. So we've distributed those throughout emergency departments. Right now, a project that we're working on has to do with the problem that I'm sure will not surprise anyone on this call, but that there's frequent turnover of nursing staff everywhere, but certainly in community emergency departments. We identify that with our partners at ENA and Connecticut AAP and other partners and the like, and have partnered with stakeholders to develop a competency-based orientation, which also could be used as continuing education as well, so that we make sure that new nurses, old nurses are consistently going through their pediatrics, and that's connecting to Joyce's kind of learning curve slide that she showed in the beginning. We have involvement in this concept of hospital recognition, but I think I'm just watching the clock and I want to make sure I save time for everybody. So if anyone's interested to talk further about community hospital pediatric readiness designation status, I'm happy to chat about that further. Sarita, I'm going to turn it back to you, my friend.
Thank you, Michael. Yes, and so the amazing work that has been done in Connecticut. So I'm going to turn it over to Michelle Megling. Michelle is the co-lead of the hospital domain for EMSC Innovation and Improvement Center, but she's also a senior project manager for the ASPR Region 5 for Kids Pediatric Disaster Center of Excellence. But she is going to go through some resources that you can get on the EIIC, EMSC that can be used immediately in your institution. So Michelle, I'm going to turn it over to you.
Okay, thank you. Can you hear me okay? Okay. So this is just a little introduction to EIIC, EMSC for you guys. Just my disclosure, EIIC is funded by HRSA, and the contents today are those of the authors and do not necessarily represent the official views and/or endorsements of HRSA or the US government. I know Joyce talked already about the NPRP hospital checklist and how it goes through the 7 domains of readiness. And it's all based on the joint policy statement, pediatric readiness in the emergency department. And along with pediatric readiness, the American College of Surgeons has recently joined in this collaborative to assure that any ACS certified trauma centers, both pediatric and adult, are pediatric ready. And they want to look at their scores. If you download this from the EIIC, you can actually use it as a checklist and find one place to start. There's a lot of resources that I'm going to be showing you. I think your first step is, did your hospital or upcoming, we have EMS pediatric readiness scoring. Did you do the Peds Ready assessment? And find out what your hospital score was. And then from there, pick one section that you want to focus on. We do have a toolkit. The NPR toolkit is based on the joint policy statement and broken into the 7 domains of pediatric readiness. So administration coordination, healthcare provider competencies, quality and process improvement, policies, procedures, and protocols, support services, improving patient safety, and then equipment and supplies and medication. When you open up a section of the toolkit, this is policies, procedures, and protocols. It actually brings up resources. Sometimes there's videos, sometimes there's journal articles to look and see what do you want and where is your need. Do you need to have mental and behavioral health policies? Do you need a triage policy? Whatever you're looking for can be found on these pages. So pre-hospital readiness, the new pre-hospital readiness checklist toolkit for EMS is very similar to the National Pediatric Readiness Policy. They will have their first survey coming up in May, so everybody be on the lookout for that. They do have a checklist to identify your gaps. And then secondly, you want to address your gaps through the toolkit. And then third, take your assessment in May. And then similar to the hospital checklist, the pre-hospital also has a toolkit going through education and competencies, equipment and supplies, medication safety, patient and family-centered care, quality improvement, and policies and procedures. On the EIC site, there's also pediatric education and advocacy kits. This is a collection of the best practice education resources to empower caregivers to deliver the highest quality of care and support children in emergency situations. We have status epilepticus, peak, a suicide, pain, agitation, and child abuse. And within each peak is a guidelines that are co-created with TREC. Information, infographics, videos, and podcasts can be found in those as well. The pain peak looks at the use of oral sucrose and other ways you can manage pain in kids. It talks about procedural pain using LET for IVs or intranasal Versed, and IV for IVs, but using LMX topical and vapor coolants. And once you get in here, like I mentioned, there's videos, and I'm going to pull up some of these websites if time allows. But you'll get the recommendations for pain, you have procedural pain and recommendations for that as well. We also have the National Pediatric Readiness Quality Improvement Initiative. This is a new free data platform that enables EDs to measure and analyze in real time and at the patient level their progress on quality metrics that improve outcomes for children. In addition to the custom dashboards that you'll be provided, the platform provides benchmarking data and reports that are shared with your hospital and ED leadership on quality and patient safety. Areas of focus include assessments, suicidality, seizures, head injury, respiratory complaints, and vomiting. I know we've talked some about disaster. The disaster domain of EIIC has created a nice toolkit. And it has actually broken down into different levels. So we have foundational levels, so that those are our sites that don't have any dedicated pediatric beds. Our intermediate are facilities that may have a nursery or a NICU or a small pediatric floor. And then our advanced are quaternary care. So this is what we build upon, starting at foundation. And as you go up, you should have foundation, intermediate, and then you're advanced if you're a tertiary center. This tool was designed to complement and augment existing disaster resources, both pediatric specific and general, rather than to serve solely as a standalone document. It was not designed to be a step-by-step guide for implementing policies. Instead, it's resources that are provided for each domain to provide more details and help implement the considerations. It's designed for any hospital, broken, like I said, into foundational, intermediate, and advanced. And making sure, does your hospital disaster policy have pediatric considerations that it needs? Do you have pediatric patients in your drills, like Joyce talked about? This is just a quick snapshot of our pediatric surge capacity. So you look at it as broken into foundational. So if you are just a foundational hospital, these are the things and basic concepts that you want to make sure are included in your surge section. And then your intermediate, you would have all the foundation and then the intermediate. And then the advanced, you would have all of these through this. When we look and talk about children with special health care needs, this is a unique population that everybody doesn't understand and everybody is unsure how to care for them. It's really good to find out if you have these kids in your area. If you are pre-hospital, try and meet with them, meet with the family before they need to call EMS. And same with the hospital. See if you can have a plan when these kids come in. Region 5 for kids is an ASPR funded to assure kids are cared for in disaster. And this is where this is coming from, Region 5 for kids. We also created a clinical school skills toolkit that'll go over some of the clinical skills that children and youth with special health care needs require. Looking at how do you care for G tube sites? How do you prepare for feeding tubes? If you're unsure how to change a trach, there's a quick video on this. Gastric tube training, a lot of things that really meet the needs of our chronic children and youth with special health care needs. Okay, I'm going to stop my sharing now, and then I'm going to pull up some of our sites. We're going to go to new share. We're going to stop share for a second. And then I'm going to go to a new share. So when we look at the EIC site, this is really looking here. Weight in kilos, non-invasive temperature, pediatric pain. We have vital signs measurement, policy examples, non-invasive blood pressure measurements. And then hopefully I have my new share. Illness and injury. Are you seeing illness and injury, Sarita, just to make sure?
Yes.
Perfect, thank you. Where we go over ESI for triage. We have some sample triage processes. Also triage qualifications and competencies. We have stuff on family-centered care. How do you support the family after the death of a child? For pediatric traumas, how do you communicate with families? And also communicating with children and families from everyday interactions and conveying distressful information. So a lot of great resources there. We also do have some stuff about death, pediatric death in the ED, how to communicate that news. Do not resuscitate orders and death of a child in the ED and the technical report as well. When we look at these, you can see like if it has a blue little character, it's the ED clinician. The yellow is the nurse. So we have these built and set up depending on like what your specialty is too as well. This is a look at our peak pain. Like I mentioned, there's the recommendation pain treatment here, and then the procedural pain. There are videos on how to do intranasal pain medication pre-hospital. videos on pediatric pain management in the emergency department. Then we have some podcasts. So a lot of resources that you can go through and look. Some of these are for EMS clinicians when you see the ambulance, and even information for patients and families, because we want to make sure that we provide family-centered care to our children and patients that come in. When we look at our disaster toolkit, you can find this, and this just scrolls through. You can download this. It can be printed as a PDF as well. We actually also have some videos and slot recordings of going through a couple of the high-level sections: pediatric surge capacity, patient tracking and family reunification, and children with special healthcare needs, focusing on just some key aspects of how to use this for those populations and those sections. Our children and youth with special healthcare needs, we were able to make this wonderful video. And then for patients, families, and provider preparedness toolkit, and then our clinical skills toolkit, which I'm going to share with you. Like I said, there's videos on emergency trach change, quick concepts, assessment of the G-tube balloon in the home setting, so stuff for families, nurses, NICU to nurseries, and NICU to nursery trach care in the home setting. And thank you for allowing me to present and share this information with you. Hopefully you guys find this helpful. But like I said, my biggest tip is this is a lot of information coming at you. Look at where you guys are in your pediatric readiness journey and pick one place to start, and just start small. Don't try and tackle it all at one time. I'm going to
Thank
turn it
you,
back
Michelle.
over.
This is that's great. And I agree with you. I think we're throwing a lot of information in this webinar, but know your site. And if there's just one thing you could work on, we just strongly encourage you to take on small bites at a time. We've all tried to take big bites before, and it's a much slower process. So if you, for instance, want to think about your patient weight in kilos, that's a really strong first step. As far as disaster policies, thinking about pediatric surge, can you take care of more than one critically ill patient? That would be a great step. Or making sure that there's pediatric representation in drills, like as you do your drill, your Joint Commission needed drills. There was one question in the chat. I'm going to just ask Joyce to come online and talk about the resource book that she had mentioned. And then Michael Goldman, I think you were going to talk about the SimBox. And if there are any other questions, please let me know.
Yep. So I'm not sure which one you guys are talking about, but I will post the website for the family reunification guideline. So there's a whole guidebook. It's great. It takes you through step by step how to set up the different areas, different issues to think about. And then I think Michelle already shared the checklist and the toolkit, and those are based. I'll share those links as well. But I'll put both of those links up, and then Goldman can talk more about the SimBox.
SimBox is an exceptionally awesome tool. It was developed not by us, but certainly colleagues of ours. And it allows for, decreasing the barrier of entry to start running simulations wherever you need to run simulations. All you need is somewhat of a Wi-Fi connection and access to the website. And literally as the simulation mannequin, you can use a pillow, you can use a doll, you can use anything. It's been described before as sort of one of those services where, those mail order cooking classes or whatever. What's one of them called? Anyway, but where all the ingredients comes in the box, you open the box and you can make a delicious dinner. It's sort of the same idea. You're able to run a simulation from start to finish with your group. And what's also really nice in ways we've used it in the past is you can do something called telesimulation, where you're running the case and someone from the local children's hospital can sort of be on a Zoom watching the resuscitation go and participate in the debrief. Lots of different ways to use this tool. Happy to talk a lot further. The website also has great introduction videos. And again, the ultimate goal is to decrease the barrier, that initiation energy to do simulations in your shops.
And if you've never done sim, it walks you through every single step from pre-briefing everybody to debriefing at the end. It's a great resource.
For the last 5 minutes, we have a really great question that we probably all struggle with is buy-in, is hospital buy-in. And so what are some things that you feel like has worked to get your management on board with implementing pediatric simulations and pediatric preparedness? And that there was also limited staff buy-in for education. I don't know who wants to take this question.
It's always good to start when you have a critical patient that's come in and you guys struggled with. That's a really good time to bring this up to even leadership, and really starting small and thinking about what opportunities do we have to improve.
Yeah, I was about to say, I think that's usually the best time. There's more motivation. I do think actually the Wall Street Journal articles that recently came out, there's been a lot more talk in a lot more emergency departments. One of the things that the Wall Street Journal has on there is basically talking about what hospitals are, what EDs are pediatric grade, which are not, and a tool to find them. And so people definitely are obviously concerned about whether or not they're on that list or not. I do think sometimes it's just good if there's beyond just that, like a specific critical care event, and beyond just the Wall Street Journal. I think also just if people actually take a look at the care of the patients that have already come in and they're really motivated and they see some gaps, being able to go back and saying, hey, I was looking at these cases and I feel like there was areas to improve here. That's another way to do it, and not just to wait for kind of a critically ill child to come through. But Goldman, you do a lot of sim, so you probably have a lot of work with getting the hospitals on board for that.
One of the things we did was tried to provide follow-up, more follow-up and less feedback on patients that were referred in from cooperative regional community hospitals that used the Yale Children's Hospital in this particular project. And that was another way to identify common cases that, where gaps in care perhaps were identified. I would also just say, like, the other carrot to consider is the partnership that the National Peds Readiness Assessment has with the trauma certification process. I recognize not everyone has trauma designation at their individual facilities, but I would imagine many do. So making sure, so if you were to take that assessment and then present it to your leadership and say, hey, we scored an X and we won't be able to get recertified from our trauma status, that could be a major emphasis on getting people to start listening to you.
Great. No, thank you. And so we have put some emails in the chat. Just so feel free to reach out to any of us, or feel free to reach out through the RDHRS. I do want to thank Paul, Eileen, and Kelly from the RDHRS for inviting us to speak. And we hope that we have provided some ideas on how to increase pediatric readiness at in your communities. So turning it over to Paul.
Thank you so much, Sarita. Thank you to all of our amazing speakers. This really was a fantastic session, and we're so incredibly grateful. As a reminder to everyone, we will be posting a recording of this webinar on our website, www.rdhrs.org. A little bit after the conclusion, we'll also be posting the slides. And for anybody who hasn't been able to see some of the resources that we've been trying to post in the chat, we will post those on the website as well. So don't feel like if you didn't catch it or if you couldn't see it, don't worry about that. Anna Sessa will graciously also will post her email. She was sharing that with everybody. Michelle, thank you for sharing yours as well. We'll post those with the slides. We're really so grateful for all of our speakers. Thank you for attending, and we look forward to our next webinar in about a month for the RDHRS. Thanks all.